started. And just to be mindful of everybody's time so they can get out right on time. Good afternoon. My name is Victoria Lancy, and I am the Rural Education Programs Manager here at the Michigan Center for Rural Health, and will be facilitating today's program. I would like to welcome everybody to today's special topic grand round on creating an effective asthma action plan. It is brought to you by the Michigan Department of Health and Human Services Asthma Program and the Michigan Center for Rural Health. Before we begin the program, just a couple reminders. If you're logged into the webinar portion and have computer speakers, you can listen to the audio through them, or if you're only listening to the program through the audio number, handouts are located on our website for you to follow along, and I also email them out to you in an email. Our handouts are located on our website at www.mcrh.msu.edu. Click on the Education tab across the top, and then click on the calendar and find today's date, and there you will see the attendance forms, the presentation, as well as the evaluation link. The attendance forms need to be emailed, faxed, or mailed back into the Michigan Center for Rural Health office, and the evaluation must be completed online. Please complete these forms within 2 weeks or by October 12th, and we can send you your certificate of participation, your certificate for the social work, or we can pass along your information to the School of Nursing, and they can forward you a certificate for the nursing program. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A component. Otherwise, we'll have a Q&A component at the end of the program. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I am pleased to introduce our speaker, Karen Meyerson, who is presenting. With that, I will hand it over to Karen.
Great. Thank you, Victoria, and good afternoon, everyone. Delighted to be here to present this webinar on creating an effective asthma action plan. As Victoria indicated, I was previously the manager of the Asthma Network of West Michigan, the local asthma coalition serving West Michigan, and I served in that capacity for 20 years. I am also a board-certified nurse practitioner, and I work in an allergy office seeing patients with asthma and allergies in the Grand Rapids area. However, just in the last month, I have changed positions, and I have joined Priority Health, which is a local health plan here in West Michigan, as the Director of Commercial Care Management. I would just like to remind everyone to please put your phones on mute and not on hold, or we'll all hear the music on hold. Thank you so much. And as Victoria indicated, feel free to type questions in the chat. I'll be happy to address them at the end of the webinar. I'm going to cover asthma action plans and how to create one. There are a couple case studies at the very end that we may or may not get to depending on the time that we want to allow for Q&A. Hopefully everyone can see my slides and can hear me well. If not, please let Victoria know and she will let me know and we can make some adjustments. We're going to begin just with a brief overview of the guidelines, the National Heart, Lung, and Blood Institute asthma guidelines. These are the most current asthma guidelines that are available. They're from 2007. And it is
I'm getting out after this. That's why I didn't do anything, did I? No.
Perfect.
I'm hearing some reverberation there, so hopefully. These guidelines were created by the National Heart, Lung, and Blood Institute, and this is from the expert panel number 3. You might hear that referred to as EPR3. This is the latest guideline.
Oh, no.
There is also, since these guidelines are now 9 years old, there are also newer guidelines that are available through the Global Initiative for Asthma, or GINA guidelines. Those are updated almost yearly, but those are global guidelines, and you may see, for example, medications there that are used in Europe and not necessarily in the United States. But for the overall guideline benefit, it is newer and more updated than these, but again, keeping in mind that these are global, those are global guidelines, these are the US guidelines. So the expert panel recommends that clinicians provide to all patients who have asthma a written asthma action plan that includes instructions for not only daily management, but also how to recognize and handle worsening asthma, including how to adjust their medications when that happens. So the guidelines say that written asthma action plans really are for everyone who has a diagnosis of asthma, but they're particularly helpful for patients who have moderate or severe persistent asthma, who have a history of severe exacerbations, or who indeed have poorly controlled asthma. A written asthma action plan may be based either on peak flow measurements or symptoms, or both. Neither one is wrong. Both are correct. It depends on the preference of the patient and the clinician. We don't see as much peak flow utilization today as we have in the past. The guidelines, when they came out in 2007, which was the third iteration of the asthma guidelines, backed away from peak flow monitoring a bit because peak flow monitoring is so effort dependent, and people sometimes would focus just on the numbers and discount their symptoms. So there really is no right or wrong. We can use the asthma action plan based either on peak flow or symptoms, or both. I always say people are using peak flow or symptoms, whichever is worse, because your peak flow can be fine, then you're symptomatic, or you may not have any symptoms and your peak flow may be dropping, and that may be more typical in those who poorly perceive their symptoms. So a peak flow-based plan, as I just said, may be particularly useful for people who have difficulty perceiving signs of worsening asthma. I will direct your attention to the state website for asthma, getasthmahelp.org. It is a great repository of all kinds of information about asthma that is in compliance with the most recent version of the guidelines, EPR3. You can log on, you can see the local statistics, even by county, for asthma. You can find information about asthma management, medications, all kinds of information there for both health professionals and patients alike. And you can even download some examples of asthma action plans from this website. So it's a great information, great referral source for people who want to learn more about asthma, and for clinicians and healthcare professionals alike. A very, very helpful website to get to know. This is what a typical asthma action plan may look like, although there are numerous versions available online. There are even some versions that are available. One in particular is the University of Michigan, that is actually one that you can fill out online and then print off. But this is what a typical asthma action plan looks like that you may be familiar with. It's based on a traffic light theory. So you can see green, yellow, and red zone just like a traffic light would be. Green means go, yellow is caution, and red is danger. We'll talk about those in just a minute. So we're going to begin with the green zone. The green zone simply means go. Patient feels good, no asthma symptoms, early warning signs, asthma is under control, asthma treatment is working, yay, everything is going well. So in this situation, we would want to list what those expectations are for well-controlled asthma. How do you know your asthma is well-controlled? If they're using a peak flow, you can use that peak flow meter range, so 80% or higher of their personal best. We would list their controller medicines, what are their daily maintenance medicines they're taking, and then maybe list potential triggers. So the green zone really is kind of a no-brainer. This just means that asthma is well-controlled, you're doing well on the current therapy, continue taking your daily maintenance medicines. Watch, though, for the rules of two, and these come from Baylor Healthcare. These are some quick rules that give you a snapshot of whether or not their asthma is under control. Are they having daytime symptoms more than twice a week? Are they having nighttime trouble, nighttime symptoms, nocturnal awakenings, coughing more than twice a month? Are they refilling their short-acting beta agonist or SABA or albuterol inhaler more than twice a year? So twice a week for daytime trouble, twice a month with nighttime trouble, twice a year refilling their albuterol. These come right out of the guidelines. Someone exceeding the rules of two would have persistent asthma or would have asthma that is simply not well controlled, and that would be throwing them into the yellow zone category. So we know everybody can have, you know, I myself have asthma. Everybody can have a bad day now and then. I can walk past a perfume counter and I can cough a little bit, use my albuterol if I need to, and I'm fine. But if that bad day is turning into a second bad day, or if someone is having those daytime symptoms more than twice a week, are using their albuterol more than twice a week, might be waking up at night due to asthma more than twice a month, and that could just be waking up because they're having some shortness of breath. Or sometimes people don't even wake up, they just are coughing in their sleep, and people in the family can hear them coughing. If they're needing 2 or more albuterol canisters in a year, if you have an albuterol canister, typical canister will have 200 puffs in it. So if they're using it twice or less a week, that canister should last them 6 to 12 months. So if they're exceeding that in a year, that, and I'm not counting that if they're using that pre-medication for, say, exercise, but they're using it because they're having symptoms, that would be exceeding the rules of 2, or they're needing oral steroids twice or more in a year. Those all tell us that that particular person's asthma is probably not well controlled. So this is just a sample of an action plan that might include the rules of 2. It looks a little bit busy, but I'll try to point it out. Hopefully you can see my cursor here. But in the green zone, we're going to ask them to monitor. Asthma is a disease of self-management, and we have to give patients the tools that they need to manage this chronic condition. So we're going to tell them, this is what you're going to look for. You're going to look for no shortness of breath, no chest tightness, no wheezing, no coughing, not using albuterol more than twice a week, if at all. Peak flow, if you're using that, is in the normal range, 80% or greater. No oral steroid or little oral steroid use. If they are achieving these goals, that would be well-controlled asthma. Use this maintenance controller medicine daily. If they're exceeding rules of 2 and they're having daytime trouble more than twice a week, nighttime trouble more than twice a month, using their albuterol inhaler more than twice a week, within a day or 2 of catching a cold, that would drop them into the yellow zone, and we're going to ask them to start increasing their medication use. And we'll talk about that in much greater detail when we get to the yellow zone. Red zone is the danger zone. So regardless of what they're taking in the green or yellow zone, red zone is an emergency, and they need to step up therapy aggressively here and seek medical care. The red zone is a medical emergency, and we'll talk about each of these zones independently. So again, the green zone, kind of a no-brainer. This is someone who has got asthma well controlled. They're doing well in the current regimen. We're going to stay the course, or possibly at sometimes we can even decrease or step down therapy. Red zone, similar. There's not much you can do in the red zone other than aggressively utilize the rescue medicines and seek care. So the red zone means we need to stop what you're doing. The patient's feeling awful. They may be very short of breath. The breathing might be fast or hard. They can't stop coughing. If they are using albuterol, it's just not helping. Albuterol is like a fire extinguisher. And so if they're using albuterol and it's not making a difference within minutes, that is a medical emergency. We don't want them to use more and more and more albuterol if it's just simply not helping, because that's definitely a danger sign. If they have retractions or they're sucking in the skin above their breastbone or in between the ribs, they can't speak in a full sentence. We call that clipped speech. They can only say a few words per breath, like, I can't breathe. We want them to increase their quick relief medicines, and I'll show you what that might look like in the red zone. Get help immediately, call 911, and get to emergency facility. This is a medical emergency. I don't care who's present at the time. I don't care where they are. They need to seek help. They may be in school, they could be at home, they could be at work, they could be anywhere. This is indicating an emergency, and they need to seek emergency care. So the red zone, we're going to list what those severe signs and symptoms are, list what that 50% or less of their peak flow, personal best, would be, how to advance their use of quick relief medicines, what does that look like when we escalate that, maybe consider adding an oral steroid, and list those emergency contacts, doctor's name and phone number, ER, or 911. We also would want them to, at this point, and this is all out of the guidelines, we would want them to escalate in the red zone their albuterol use. Whatever we can do to relieve that shortness of breath or the severe symptoms while they're seeking care, or while they are waiting for the ambulance, or while they're on their way to the hospital. So dosages for asthma exacerbations, the usual dose, as we all know, is 2 puffs of albuterol every 4 hours as needed. However, during a severe exacerbation, the guidelines does allow us to escalate that dose. For children and adults, they can go up to 4 to 8 puffs, and they can do that every 20 minutes for up to 3 doses. Then we want them to split that and try and stretch that out every 1 to 4 hours as needed. I will tell you, if someone is needing 4 or 8 puffs and they are doing that back to back for up to 3 doses and it's not working, that's definitely an emergency, red flag. And quite honestly, if someone is needing that much albuterol use, they probably should be seeking care anyway, just to make sure that their asthma is indeed quieting back down. And after that, if someone cannot go 4 hours without using albuterol again. Certainly they need to take it as often as they do, every 1 to 4 hours in a severe exacerbation. But if that's not holding them for 4 hours and they're needing it every hour, major red flag. And obviously at that point, they should also be seen in the emergency department as quickly as possible. So they can accelerate the dose of their quick relief medicine, their albuterol, but as they're accelerating the dose, they also need to be seeking care at that moment too. Sometimes providers will allow for a patient to have prednisone on hand, and they can add that in as part of the red zone plan, again, while they're waiting for care or as they're seeking care. For children, a common dosage is 1 to 2 milligrams per kilogram per day. Sometimes they'll allow them to do a short course for 3 to 10 days. A typical dose that you'll see sometimes in the outpatient setting is 1 milligram per kilogram a day for 5 to 10 days. For adults, a typical range is 40 to 80 milligrams a day for 5 to 10 days. So a common short-term course for an exacerbation might be 40 milligrams a day for 5 to 10 days. Again, these are typical outpatient courses that a provider may feel comfortable if a patient has been educated how to use prednisone properly. But we want to avoid having to go to the emergency room. We would like to avoid oral steroids if possible because they can have multiple side effects if used for a long-term basis or used multiple times within the course of a year. So what's the best way to avoid those severe exacerbations that would send someone to the emergency department? That's where the yellow zone comes in. The yellow zone really is the make or break zone. What a patient does in the yellow zone can really sometimes determine the course that that asthma exacerbation is going to take. So in the yellow zone, that's indicating caution. Patient just doesn't feel good. First sign of a cold, a cough is just starting, might be having some early chest tightness or pain, but they might even have some early signs of allergies if allergies often trigger their asthma. They might get an itchy nose, or they might be doing some nose rubbing. We call that the allergic salute. They might get an itchy chin. They might get a scratchy throat. They might start clearing their throat. That's my daughter. I have a grown daughter with asthma, and she clears her throat when she's having early signs of asthma trouble. And she was living in California, and I would be talking to her on the phone, and I hear her clearing her throat. I'd say, Jennifer, what's going on with your asthma? And she'd say, how did you know? I said, I can hear you clearing your throat. Well, starting to get a cold, my chest is getting a little tight. I could tell from hundreds of miles away that she was having trouble just by that one sign. So at this point, that would be the first sign of an asthma flare, potentially. For me, with my asthma, usually an upper respiratory infection is the very first trigger for me. So when I get a cold, and that just means a scratchy throat, you know, you just feel maybe a little achy, throat is scratchy. At that point, I'm going to escalate my controller med before it hits my chest. If I sit and wait a couple days until it makes a beeline to my chest and I'm coughing and I'm wheezing, the horse is out of the barn by that point, and I probably will end up on oral steroids and have a major exacerbation. If I can head it off at the pass and treat it earlier rather than later, I can often change the course of that exacerbation and prevent it from getting to that point. That's what I'm talking about when we're talking about avoiding emergency department visits and avoiding oral steroid use. So if we can add or increase asthma medication according to the asthma action plan, we might be able to reverse that trend. But we have to start it early. The whole secret to treating asthma is catching it early. So we want to recognize what those individual early warning signs are, and they may be different for everyone. We want to use quick relief medications, escalate the controller medication, possibly even add the oral steroids if necessary, just for a very brief time, short term, even in the yellow zone. If the provider feels comfortable, the patient can use that capably. So we're going to look for gradual worsening. Are we exceeding the rules of 2? Sometimes there's an acute worsening within a day or two if it's severe, or a first sign of a viral infection. As I said, when I worked as a nurse practitioner, it was very rare that a patient would tell me that they don't get an asthma flare with a cold. Viruses are notorious for triggering asthma exacerbations. Even a simple common cold. Those of you who don't have asthma, you may get a common cold and shake it off in a couple days. Those of us who have asthma may get the very same virus that you had, but it'll settle in our chest and indeed trigger a full-blown asthma exacerbation. If we find the peak flow meter readings are dropping by 20%, again, those of us who are using peak flow readings would all indicate early warning signs, and this is the prime time for action. So we want to assess or recognize those early warning signs, and then the first step would be to use our albuterol inhaler, usually 2 puffs every 4 to 8 hours if needed. We can escalate the therapy if need be. 4 to 8 puffs. That can be every 20 minutes up to an hour. That would be early signs of a more severe exacerbation, but we do want to try to space it out every 4 hours thereafter. So we want to make sure that even in mild to moderate exacerbations, inhaler spacer technique. So if someone's using albuterol with a meter dose inhaler, an MDI, and a spacer, that is believed to be as effective as a nebulized treatment, providing they have been coached into using an inhaler spacer correctly. In fact, in many emergency departments around the country, they are transitioning from nebulized therapy to inhaler and spacer. It is quicker, it can be as effective, although sometimes patients will tell you they just perceive more relief with a nebulizer, and that's perfectly fine as well. So we're already adding now their quick relief medicine in the yellow zone. The next step would be to adjust controller medicine. So if they're not on an inhaled steroid already, we may add an inhaled steroid for 1 to 2 weeks. And this would be an interim step, much lower dose than adding a course of oral steroids. If they're already on an inhaled steroid, we can increase that dose. The question is, do we double a dose? Do we triple it? Do we quadruple it? Well, doubling the dose of inhaled steroid for somebody who was already on it in the green zone was the typical clinical strategy, but studies showed that this really didn't make much of a difference, didn't improve outcomes, didn't really prevent that progression of an asthma exacerbation. The questions were the study designs flawed? Did the people simply intervene too late? So now we've been actually looking at the quadrupling dose of inhaled steroid in the yellow zone early on, and studies indicate this can be effective, but the intervention should take place very early on. So asthma action plans will often indicate that patients can at least triple the dose or even consider quadrupling the dose of an inhaled steroid. One study actually suggested quintupling the dose of inhaled steroids, but increasing inhaled corticosteroids, sometimes adding oral steroids is best if by increasing the inhaled steroids, they're still not making an impact on those symptoms in the yellow zone. So there are now, I call them new practice parameters, but they really have been out since 2014, that many practices are starting to adhere to for the yellow zone. This is from the Quad AI, the American Academy of Asthma, Allergy, and Immunology. This is the management of acute loss of asthma control in the yellow zone, a practice parameter, and it's from the Annals of Allergy, Asthma, and Immunology from 2014. So if you would like to look it up, there is a reference right there. There are 8 steps to this practice parameter, and I'll go through them right now. The first is provide patients with an asthma action plan that includes instructions for recognition of loss and control, very much consistent with the national guidelines in 2007. Activate the yellow zone plan with acute loss of asthma control, again in accordance with the guidelines. Activate the yellow zone plan at the onset of a URI, upper respiratory infection, common cold, again consistent with the guidelines. Escalate asthma therapy in the yellow zone. Again, that's also consistent with the guidelines. This is where the change may come in just a little bit. So for quick relief asthma therapy, the new practice parameter recommends 2 to 4 puffs every 4 to 6 hours. If they exceed 12 puffs per day, that's when they should be contacting their provider. For patients being treated with a daily inhaled corticosteroid, this practice parameter also recommends consider increasing their dose by 4-fold. And I'll show you what that looks like in some examples coming up in just a minute. For children under 6 years old with risk factors for asthma, consider adding a high-dose inhaled corticosteroid or adding oral montelukast, which is Singulair, at early signs of a wheezing illness. And finally, for patients with mild to moderate asthma, consider recommending symptom-driven use of an inhaled corticosteroid with a short-acting beta agonist or albuterol for control of yellow zone symptoms. So really, very much following the asthma guidelines, just spelling it out maybe a little clearer in terms of what the recommendations are. So they're saying certainly we want to accelerate or escalate the albuterol use in the yellow zone, and we want to accelerate what those daily maintenance medications are, especially inhaled corticosteroids, or we can even initiate them at that point in the yellow zone if they're not currently on them. So again, just to review, quick relief, we want to escalate the dose. Inhaled corticosteroids, we can double, triple, quadruple, quintuple. Right now, some of the more current evidence is settling on quadrupling that dose in the yellow zone. can proceed to oral steroids, step 4, if they're not improving. So, question I often get, wow, isn't that a lot of inhaled steroid? You're telling me to use 4 times the dose of my inhaled corticosteroid in the yellow zone. That's a lot of inhaled steroid. Well, indeed it is, but if you still compare inhaled steroids to systemic steroids, we're probably still not achieving the dose of an oral steroid. Inhaled steroids are dosed in micrograms. Oral steroids are dosed in milligrams. So a microgram is 1,000th of a dose of a milligram. It's 1,000th of a milligram. And just to give you a quick example here, a usual prednisone burst, as I mentioned earlier, is say 40 milligrams a day for 5 days. Someone has an exacerbation, they are using their albuterol, they might have even escalated their inhaled steroid, tried that for a day or 2 or more and didn't make a difference, and they're still continuing to worsen, or they're just simply not improving. A provider will often then put them on a course, or certainly an emergency department would put them on a course of oral steroids. So a typical course is 40 milligrams a day, 5, 10 days sometimes. That is a total of 200 milligrams or 200,000 micrograms. By way of comparison, let's just take a look at perhaps Advair, which is an inhaled corticosteroid and long-acting beta agonist combination. So Advair 100, which is the lowest dose, contains 100 micrograms of fluticasone, which is the steroid. So if you took Advair twice a day, that's 200 micrograms of the steroid, the usual dose, it would take you 1,000 days, 2.7 years of regular use to equal the amount of steroids in one burst of prednisone on a microgram per microgram basis. So even quadrupling the dose of inhaled corticosteroids, you're still not going to be exceeding the dose of an oral steroid because you're comparing micrograms, 1,000th of a dose, to milligrams. So let's look at a couple examples. Let's put this into play here and see what that might look like in a patient who, first of all, is perhaps not on a daily control medication. This might be someone who has intermittent asthma. They do fine most of the year. They're not having any regular symptoms. Maybe once a year they get a cold and it makes a beeline to their chest, and that triggers an asthma exacerbation. So in this situation, someone's not taking anything daily. We would tell them to, first of all, step 1, monitor to see their asthma is not well controlled. They're catching a cold here, or they're starting to exceed the rules of 2, daytime trouble, nighttime trouble, using albuterol more than twice a week. The first thing is use your short-acting beta agonist or your albuterol. Usual puffs, the usual doses are 2 puffs every 4 hours. They can use 2 or 4 or 6 puffs, and they can do that up to 3 times up to an hour. If they're using higher doses and they're not better, they should seek help. But even if they are using higher doses and you know what, they're improving, but they're not out of the woods yet, we could add at this point an inhaled steroid. Put them on something like a Qvar or a Flovent or an Aerospan or Pulmicort, any one of the typical inhaled corticosteroids on the market right now. And they could use perhaps 4 puffs and do that twice a day, just for a week or 2, 5, 10 days, even 5 days. If they just add that inhaled steroid in at this point, by the end of 5 to 10 days, hopefully they're out of the woods and the exacerbation is quieted back down. If they have done this and they're not making progress, that's when they probably should be calling their provider. But oftentimes if we add this, and again, the secret is adding it early, if we add this in and we're a little more aggressive and add that early, we might be able to prevent that progression or that decline of that exacerbation where they can deteriorate into the red zone. If they are in the red zone, that's a danger zone and they need immediate care. Okay, what about a patient who is already on an inhaled steroid? Any one of those that I mentioned or any of the others on the market, typical dose is 2 puffs twice a day. So they're using this on a daily basis and they've hit the yellow zone. They've exceeded the rules of 2, they're catching a cold, their peak flow is dropping, something has changed. That's the difference of the yellow zone. They're not doing well, something has changed, early signs of change. Add their short-acting bronchodilator, and at this point, this is when we could quadruple the dose of the inhaled corticosteroids. So they can go, instead of 2 puffs twice a day, they could do 4 puffs of that inhaled corticosteroid, and they can do that 2 or 3 or 4 times a day. They could take as many as 16 puffs a day. That would be quadrupling their dose. And doing that for 1 to 2 weeks, 5, 10 days, whatever it would take to get that episode quieted back down, However, you want to warn them to use their inhaler with a spacer and rinse their mouth, because especially using higher doses, they're at higher risk for developing candidiasis or oral thrush if they're using higher doses of the inhaled corticosteroid. Try that for at least a couple days if they're not improving. Sometimes they will have a script for oral steroids to use at that point, or definitely call a provider if by quadrupling the dose they are not making progress. They need to see their healthcare provider. If they do deteriorate into the red zone, that plan takes effect then, and that's a medical emergency. But again, depending on what we do in the yellow zone and how early and how quickly and how aggressively we treat that deterioration, that can make or break what happens with that patient and their asthma symptoms. Okay, you may be asking yourself, well, what about if they're on a combination therapy? What if they're on Advair, Symbicort, Dulera? Those are all fixed dose medications. They include an inhaled corticosteroid and a long-acting bronchodilator. Those are set at twice daily use. There's newer ones that are even once a day. You cannot exceed that dosing guideline. You simply cannot. Not because of the inhaled steroid, but because of the long-acting bronchodilator. If you exceed that dose, then you're exceeding the long-acting bronchodilator, and that's not permissible. So what do? Well, in these situations, we would say go ahead and continue to use your Advair or Dulera or Symbicort or Brio, or whatever you've been prescribed on a regular basis for whatever that typical dosing is. But then in this situation, add your albuterol, and if that's not helping, you can add a separate inhaled steroid in the yellow zone. So continue taking your Advair, Dulera, Symbicort, Brio, as you would before, but now you can add to that something like Qvar or Pulmicort or Aerospan or Flovin. You can add just the steroid component and do 2 puffs of that, and do that 2 or 3 or up to 4 times a day, again, for a week or 2, 5, 10 days, just to boost up that inhaled corticosteroid without touching that long-acting beta agonist. Just do that for 5 to 10 days, and sometimes adding a little bit more inhaled steroid on board will quiet down that exacerbation if we catch it early and prevent them from deteriorating into the red zone. So they would have to have a separate script for an inhaled corticosteroid alone, and they would reserve that and use that just in the yellow zone. If that doesn't work and they end up in the red zone, that's when the red zone plan would go into effect. So just to summarize quickly, the asthma action plans are important, but they should be part of a broader asthma education effort. And every patient is different. Asthma action plans will be different, and they can change over time. They need to be adjusted on a regular basis, especially for children, because they're growing so quickly. I think the question comes down to how much do you believe that patient should be allowed to self-manage? If I do see sometimes asthma action plans written such that in the yellow zone, it may say use albuterol, if you're having early signs of trouble, every 4 to 6 hours as needed. And if that's not helping, or if they're not making progress, call the office. Oh, that's fine. That would be fine, but if they were given the tools perhaps to escalate the controller medicine, maybe they could be doing that on their own. So if they are home at night or on the weekends, or they want to just try this first, they're really not in distress, but they can tell that the cold is settling in and they want to get on top of that asthma flare. Sometimes by allowing them to do this, we can help, again, head that off of the path, slow down that progression or halt that progression into the red zone and stop it there in the yellow zone and bounce them back into the green zone. So that these plans allow them to self-manage, and that's why the new practice parameters as well as the guidelines do recommend that the plans have some substance to them that allow a patient to self-manage. So I think we do have some time here at the end just to go through a couple quick case studies, what that looks like in terms of how to adjust medications, and maybe getting into even a little bit of diagnosis here, how we can tell when someone has asthma and how we can tell whether or not it's well controlled. So we're going to take a look at Tyler first. Tyler is a 2-year-old with a history of wheezing. He's got frequent coughs. He's had 3 emergency room visits for worsened respiratory symptoms in last winter. The first 2 ER visits, he was treated with an antibiotic. That's not uncommon. Sometimes wheezing episodes in children are misdiagnosed as pneumonia or respiratory infections. At the first 2 emergency room visits, I said he was treating with antibiotics. And then at the last visit, he was also treated with albuterol. He was hospitalized last March with bronchiolitis, which was culture positive for an infection called RSV, or respiratory syncytial virus. So I'll give you a couple clues here. He was treated with albuterol, and he got better. Sometimes that helps clue us in, especially in the little ones, to a diagnosis of asthma, because most providers can't do lung function studies on children 5 or under. Certainly, pediatric pulmonologists can. They can do some passive pulmonary function testing, but most providers can't. So this helps us clue into a diagnosis of asthma. Plus, RSV is a very common infection that many babies and toddlers get. In children in particular who have a genetic predisposition to asthma, sometimes RSV will turn on the asthma switch and they will develop asthma from that point. So at discharge on this last ER visit, Tyler's mother was provided with a nebulizer, was instructed to give him inhaled albuterol 4 times a day until the cough had resolved. He was also given a 5-day course of oral steroids. He got better, he was fine. 3 months later, his cough is back. So he just had yet another ER visit and completing yet another course of oral steroids. So what are we dealing with here? Is this someone, we certainly can see wheezing as a result of viral illnesses in children and toddlers. Their airways are smaller than adults and they can become compromised quickly with a response to viruses. Or could we be looking at a diagnosis of asthma? So in children of this age, it may be difficult to diagnose the cause of viral-induced wheezing, but we also know that underdiagnosis of asthma is very, very common, especially in children who wheeze only when they have a respiratory infection. So oftentimes these children are indeed misdiagnosed as having pneumonia or bronchitis, and they receive antibiotics that may not be the appropriate treatment. So what we are looking at here is, and this is something to keep in mind, is the Asthma Predictive Index, API, and this is out of the guidelines from 2007. This is looking at high-risk children, and this is children under the age of 3, who have had 4 or more wheezing episodes in the past year, and some would even argue 4 or more coughing episodes in the past year that lasted more than a day and impacted sleep. These children are much more likely to have persistent asthma after the age of 5, which is thought to be lifelong at that point, if they have either one of the following. So you have another term is transient wheezer. So this is a child who has transient wheezing episodes. They are much more likely to be considered having asthma if they have one of the major criteria, such as a parent with asthma, if they have a physician diagnosis of atopic dermatitis or eczema, or they have positive sensitization to aeroallergens, and this is either by blood test or by skin prick test. So they've shown positive to aeroallergens, such as cat, dog, tree grass, weed pollen, dust mites, mold, that kind of thing. If they have any one of those criteria, plus they've had these wheezing or coughing episodes, this child most likely will go on to develop asthma. Or they have two minor criteria. They have food allergies, and or they have blood eosinophilia, and or they have wheezing apart from colds. So this is the Asthma Predictive Index. So this was a study done a number of years ago, and they followed this birth cohort through 13 years of age. And they found that the majority of the children diagnosed with asthma after 6 had a positive Asthma Predictive Index before the age of 3. And the majority of children who did not have asthma after the age of 6 had a negative Asthma Predictive Index before the age of 3. So it's just, no one has a crystal ball. That's why I show the crystal ball, but no one has a crystal ball and can say definitively this child who's wheezing at the age of 2 is going to have asthma. But if that child has had these repeated wheezing or coughing episodes, has a parent with asthma, we can feel more confident in a diagnosis at some point saying this child has asthma. So most asthma clinicians believe that once a diagnosis is made, we would use a stepwise approach to treating asthma. So the guidelines recommend that patients under 5 with persistent asthma be treated with an inhaled anti-inflammatory medication and also receive a short-acting beta agonist on an as-needed basis. Corticosteroids are the first line of treatment for persistent asthma regardless of age, and I'm talking inhaled corticosteroids, not oral like prednisone. So every child with asthma should have a prescription for a short-acting beta agonist used as needed as well. So this is an asthma diagnosis tool that was developed by the state of Michigan. It's based on the asthma guidelines. It can also be found on getasthmahelp.org, looking at how we determine how severe asthma is when it's diagnosed. Are we looking at intermittent asthma, or persistent, mild, moderate, or severe. And this is really the line of demarcation between intermittent and persistent. Anybody who has intermittent asthma, has asthma very infrequently, that person would probably do very well on just a albuterol inhaler as needed. But anybody who has persistent, mild, moderate, or severe persistent needs to be on a daily controller, and the guidelines suggest that the most effective daily controller medication for all ages from 0 to 105 would be an inhaled corticosteroid. So for Tyler, we would say that he should be given an albuterol inhaler and should be put on an inhaled corticosteroid because of the frequency of these wheezing episodes. So again, for Tyler, we're looking at, he's all ages, but he would probably be considered step 2. If we go back here and look at probably mild persistent, and that takes you down to step 2. So that severity will marry that level of severity to the stepwise approach, and there's step 2. So we would probably start him on a low-dose inhaled corticosteroid and also give him albuterol to use as needed. Now that said, had he had more severe symptoms, more frequent wheezing episodes, anything else that might have thrown him into a higher category, we could start at a higher step and step down. In this situation, because he's probably step 2, we can start here. If we need to, we can step up therapy. So the whole stepwise approach is very fluid. We start them, this is just a starting step. We're going to start him at step 2, put him on the inhaled corticosteroid, give him albuterol to use as needed, and see how he does from there. We want to see him, at least every 6 months, see how he's doing. If he does well, we can consider stepping down therapy at that point. So everyone who cares for Tyler needs to receive instructions on demonstration and return demonstration that addresses how, when, and which medicines to provide him, and also develop a written asthma action plan that is shared with all of his caregivers. So everyone on Tyler's care continuum is aware of what to give him on a daily basis, and more importantly, what to do at the very first sign of trouble. When any change occurs and he drops into the outlow zone, everyone needs to know how to respond to that drop. And everyone also needs to know how to review the inhaler spacer technique. At his age, we would be using a face mask for that spacer, and then oral rinse, and know how to use those medications appropriately. So a couple questions here that we get quite frequently. What are the long-term effects of daily medication on growth and puberty? The long-term effects of daily medication on growth and puberty are still being studied, but we do know that, and what we found is that there may be a slight impact on growth velocity or even potential growth, even on inhaled corticosteroids, by perhaps a centimeter. But we also know that under treatment or poorly treated asthma itself can suppress growth. We know that when a child is not getting enough oxygen, they're not going to grow to their optimal height. We know when asthma is not optimally controlled and they're going on repeated course of oral steroids, that can definitely suppress growth. So we are going to weigh the risks and benefits of using these medications. It is believed to be that the benefits will far outweigh the risk of poorly controlled asthma. But that said, that's why we want to step down therapy if we can. But if we can't step off therapy without risk of losing control, we're going to keep him on the inhaled corticosteroid. So treatment with corticosteroids, both oral and inhaled, have been shown to impact growth. The goal of asthma therapy the goals are to have patients be on the lowest possible dose of the least number of medications. And I always told patients, we want you on the least amount of medication, the lowest dose, to be able to control your asthma. But controlling asthma is still the primary goal. And most asthma experts believe that if treatment is initiated early and at the appropriate doses, growth and puberty will not be significantly impacted. Potential small risk of adverse effects on linear growth from the use of inhaled steroids is well balanced by their efficacy. I think we have a few minutes left, and we'll just quickly go through Sharana and leave a couple minutes left at the end for a Q&A. So Sharana is a 15-year-old high school sophomore with asthma. She was well with the usual colds until the age of 6. Then she began having more lower respiratory tract illnesses, and she did get better during spring and summer, but then she developed sneezing, coughing, and chest tightness, shortness of breath with exercise, and wheezing on a pretty regular basis in the early fall, and those symptoms began to persist through the winter months. So she has an albuterol inhaler that she uses at least twice a day when she needs it, which is almost daily right now. She also was given an inhaler she was supposed to use twice a day, but she forgets to use it because you know what, when she uses it, it really doesn't seem to make any difference. When she uses the albuterol, she can feel that. She can feel the airways opening, and she can feel it working. When she has that other one that she was given on a daily basis, it doesn't really seem to make much of a difference whether she uses it or forgets to use it. So she forgets it more than she uses it. So she'll tell you the albuterol inhaler works, and the other one really didn't seem to make much of a difference. She used to participate in sports, but then she had to quit because she would get too tired. And she admits that she wakes up by coughing a couple nights a week, and more often if her family uses their fireplace. So she also coughs when she visits her girlfriend's house because there's a cat there. Her asthma control test score is 17. So asthma control test is a validated measure of asthma control in the last 4 weeks. It's a validated score. So a score of 20 and above is well-controlled asthma. 16 to 19 is not well-controlled asthma. 15 and below is very poorly controlled asthma. So she's at 17, not well-controlled. So both her daytime symptoms, her nighttime symptoms, and her asthma control test score drop her into the not well-controlled category. So she should be assigned to the category that demonstrates the most severe findings. And we know that her asthma is also triggered by possibly allergies and other triggers. So now, on every follow-up visit, the other grid that I showed you earlier was severity. That's when someone is newly diagnosed or they've not been on controller therapy. But now, in every follow-up visit, we're going to assess level of control. So this is Sharana, and she's going to fall into this not well-controlled level based on daytime trouble, based on nighttime awakenings more than a couple times a month. She has some activity limitations. She's just not active because she gets too tired, because she can't be active because of her breathing. And also the ACT score is 16 to 19, so she was at 17. So all of those features, but really all it's going to take is one of them to fall into the not well-controlled therapy. What this is telling us then is step up at least one step and assess her response to therapy in 2 to 6 weeks. So Sharana is now at least at step 3. And she was given a low-dose inhaled steroid and a long-acting beta agonist, but didn't really perceive that it was helping because she wasn't using it on a daily basis. So we're going to get her back on track and ask her to use this again on a daily basis. Explain to her that instead of the fire extinguisher of using albuterol on a daily basis, this is helping prevent the fire from occurring to begin with. This is going to help reduce the smoldering inside those airways that can trigger into a fire. So this is going to help protect those airways and reduce inflammation and reduce her response to triggers and keep her asthma under control. The key is, though, that she has to use it daily, because it's not going to be effective if she's not using it daily, and she's not going to see the optimal benefit from this medication until she's given it a fair trial of at least 2 weeks. So questions she may ask is, will I have to take this medication for the rest of my life? Will I get addicted? Asthma is a disease that may come and go, but it cannot be cured. We call it maybe perhaps going into remission, so it can become quiescent, and at some point people can go off their asthma medicines, but it will never go away. So we want to treat asthma aggressively with anti-inflammatory therapy, prevent it from getting worse, and current recommendations are that therapy can be reduced when symptoms are under control. So we will continue to lower your dose and possibly even stop your medicines once control is achieved, but we're always going to monitor to make sure we don't lose control. So we would expect that in many children, asthma improvement gets better as they get older. We would hope that her asthma would improve. Asthma medicines are not addictive, and taking them does not make her more dependent on taking them. Once the medications reduce inflammation in the airways, she will likely need less medicine. Another question about steroids. Steroids, I've heard, are bad for me. Any drugs taken in excessive dose can be bad, but steroids you're referring to are more systemic corticosteroids. Patients will often confuse steroids, for example, the steroids that athletes might abuse, and those are anabolic steroids. Those are bodybuilding steroids. These are catabolic steroids. These are anti-inflammatory steroids, and they don't trigger the same reactions that the other steroids do, and they're not addictive, or you cannot abuse them. The inhaled steroids avoid the systemic effects because they target those effects to the lungs. So inhaled steroids, when you're inhaling these medicines, they really target the lung tissue specifically, get broken down very quickly. I wouldn't expect to see systemic effects from taking these medications in the usual doses. So once they're absorbed from the lungs, they're broken down quickly and inactivated. If taken in very large doses, they can produce some bad effects. But using a spacer and rinsing the mouth will help decrease the oral pharyngeal deposition, which will help prevent them swallowing and get them absorbed by the gut and trigger systemic reactions. So she may be non-adherent, probably related to her age. She just has a poor understanding. She doesn't understand asthma management. She doesn't understand the use or the need or the benefit of taking these daily control medications. She also has some allergic and non-allergic triggers that should be addressed. So based on the guidelines, she may be considered a candidate for referral to a specialist, allergy, pulmonary specialist. And they can also help her better define what those triggers are and do the appropriate testing. So I'll leave it here. I'm going to stop the sharing, and I'm going to go to, or maybe Victoria can help me get to the chat room.
Yep.
Oh, there we go. There we go. Okay. And I see there is one question already that's come through, and that is, what is the correlation to asthma with atopic dermatitis? That's a great question. Atopic dermatitis is also known as eczema. And the belief is that atopic dermatitis or eczema sometimes can be actually a precursor to the development of asthma. It's called the allergic march. So we'll sometimes see babies who have that genetic predisposition to asthma. They may develop eczema as an infant. As they get older, they live through a couple pollen seasons, or they could become exposed to known allergens, like living with cats or dogs, or living through a couple pollen seasons. They could develop allergic rhinitis. So that's kind of the second step. And sometimes the next step would be asthma. So it's all sort of in the same autoimmune family, where it starts perhaps with atopic dermatitis or eczema, can march to allergic rhinitis, can march to then asthma. They can all certainly come out at the same time, but sometimes we'll see that if we see a baby with atopic dermatitis, especially if that baby has a family history, especially parental history of asthma, we're going to watch that baby closely for those respiratory symptoms. Other question?
I'll unmute the lines, and it will take any other questions or comments. So I'm going to unmute the lines. Just be mindful that we will hear anything that you have going on in the background. So just be mindful of that. And if you want to mute yourself, you can go ahead and re-mute yourself. Okay. So now all the lines are unmuted. So if you have a question or comment, please, you can go ahead and state it now.
This is Joy Pomeroy. I'm a nurse care manager with Central Wellness Network, and I'm wondering, with the website that you gave as a referral with action plans that can be downloaded,
yes.
If I do that with an individual and work with their primary care doctor to develop that action plan, it would be based on the medications that their primary care doctor has onboarded?
Absolutely, yes.
Could I do that?
Yes, yes. So you may want to check first to see if they have an action plan. You may want to check to see if their provider has their own version of a plan. Sometimes they have their own set plan that they like to use, and maybe the patient or the member they're working with didn't realize that's what the plan was, or they never received it, or they lost it. You may want to check there first, but if they truly don't have a template, you can certainly download one of those. And then what you can do, if you feel comfortable, is just, you can certainly fill in their daily controller medicines in the green zone, and then fill in albuterol in the yellow zone. I wouldn't make any adjustments or escalate the controller medicine until that would be cleared with their provider, because they would be the ones to direct that. But at least it's a starting point. And say, take this back to your provider. Sometimes, if you consult with the provider and say, do you want me to take a stab at this first and then send it to them for signature? Ask them if you feel comfortable with escalating the controller med in the yellow zone. It really comes down to what that relationship is like with the provider. But I wouldn't do any of that without their permission. Certainly have them sign off on it if that's done. But typically what people will do is fill in just their daily control medicines and the quick relief medicines, and leave the escalating of the controller meds up to the provider.
And it would be valuable to review the specific triggers for them and go
Absolutely.
through the red yellow zones. That's very helpful.
Absolutely, yes, and you can even, if they're not familiar with, when you're talking about escalating the controller meds, because some providers may not be, you can go to that reference, the yellow zone practice parameters. That's evidence-based. You can download that whole article and share it with them, and they may find that very informative.
Okay, thank you so much.
You're welcome.
Are there any other questions or comments?
Oh, we just want to thank you very much from Traverse City, and it's wonderful to get that reminder about getasthmahelp.org.
Yeah.
I used to give that to all my children's special health care clients in a bookmarker form, and so it just reminds me to get something to do that again.
Yes, well, great. Thank you. Yes, and it's just really a great resource. Even if you're just curious as to the prevalence data or hospitalization data in your neck of the woods, you can actually even look at county by county and see the local statistics, all kinds of really good information for patients too. You can download some patient handouts and they're not copyright protected, and make copies and hand them out. It's just really a great resource.
Well, thanks so much.
You're welcome.
Any other questions or comments? Okay, if we don't have any other questions or comments, please or if you think of them later, please feel free to, you can always email me them, or you can indicate them on your evaluation, and I can pass them along to the speaker. Thank you for joining us, everybody, and have a wonderful afternoon.
Thank you. Thank you, Victoria. Thank you, everyone.